The human body maintains a constant stream of electrical impulses. To ensure these signals do not exceed physiological limits, cells utilize an inhibitory mechanism. This mechanism is the GI protein-coupled receptor. When triggered, the GI receptor initiates a precise intracellular sequence, starting with the downregulation of adenylyl cyclase. This results in a drop in cyclic AMP, which in turn reduces the activity of protein kinase A. Simultaneously, the receptor's beta-gamma subunit alters membrane permeability by closing inward calcium channels and opening outward potassium channels. Potassium moves out of the cell into the extracellular space, while incoming calcium is blocked at the membrane. As positive ions leave, the cell's internal voltage decreases, leading to a negative charge and a state of hyperpolarization. In this hyperpolarized state, electrical conduction slows and the release of neurotransmitters is suppressed. This diagram illustrates how the core GI pathway, lowering cyclic AMP and forcing potassium out, acts as the inhibitory mechanism for the heart, sympathetic tone, and central dopamine pathways. This is the MAD2 framework. By tracking where this receptor is expressed, we can link a single intracellular ion shift to the clinical behaviors of 3 distinct systems. We begin by examining the inhibitory effects on the myocardium. In the blue panel, the GI pathway operates through the M2 muscarinic receptor. Located on the cardiac node, it serves as the primary vagal brake on the heart. M2 activation opens the necessary channels, driving potassium out and hyperpolarizing the SA and AV nodes. This delays electrical conduction through the AV node, which reduces the overall flow rate. When this vagal effect is excessive, the patient enters symptomatic bradycardia, where the heart rate is insufficient to maintain perfusion. The pharmacological intervention for this state is atropine. As indicated by the blue lock icon, atropine acts as an antagonist, physically blocking the M2 receptor. Blocking the receptor stops the outward flow of potassium. The SA and AV nodes regain their resting voltage and depolarize, increasing the heart rate. Atropine lifts the GI brake from the cardiac node, allowing the heart's intrinsic pacemaker to resume its natural firing rate. The same mechanism applies to the gaps of the central and autonomic nervous systems. As shown in the purple panel, the GI pathway maps to the alpha-2 adrenergic receptor, which acts as a presynaptic brake. A drop in cyclic AMP at this site reduces the influx of calcium into the nerve terminal. Without calcium entry, the exocytosis of norepinephrine vesicles is prevented. The result is a reduction in central sympathetic outflow and a decrease in insulin release. Clinicians utilize clonidine as an alpha-2 agonist to engage this presynaptic brake, treating the norepinephrine surges seen in hypertension and opioid withdrawal. In acute care settings, the target shifts to sedation using dexmedetomidine. Dexmedetomidine utilizes this alpha-2 pathway to directly suppress the locus ceruleus, rapidly inducing a state of symphylasis and sedation. Tizanidine applies presynaptic suppression to motor neurons, resulting in muscle relaxation for clinical spasticity. Unlike atropine, which prevents the brake from engaging, these drugs actively stimulate the alpha-2 receptor to attenuate sympathetic activity. We move finally to the deeper structures of the central nervous system. In the green panel, the GI pathway maps to the D2 dopaminergic receptor, a modulator for movement and nausea. The primary geographic target is the chemoreceptor trigger zone, or CTZ. Under normal conditions, D2 activation suppresses prolactin release and transmits nausea signaling through the CTZ. This provides a therapeutic target for managing emesis and acute psychiatric agitation. Metoclopramide acts as an antagonist, locking the D2 brake in the CTZ to shut down nausea pathways while accelerating gastric emptying. For agitation, haloperidol and droperidol target these same D2 pathways. Shutting down this specific signal de-escalates psychiatric symptoms. This lock stabilizes central pathways by blocking the dopamine signal. Whether managing the stomach's trigger zone or intervening in a psychiatric emergency, these outcomes rely on strategically disabling the internal GI dopaminergic brake. When viewed as a whole, these individual targets form a single pharmacological system. This dashboard represents the MAD2 architecture, showing the full scope of cellular inhibition across these systems. In the bottom right, we see the unified chain. M2, alpha-2, and D2 all feed into the same inhibitory lever, treating bradycardia, inducing sedation, and halting nausea are different clinical outcomes that all stem from the same hyperpolarizing shift of potassium ions. The clinical result is determined by geography, whether the GI receptor is located on the SA node, a presynaptic terminal, or the CTZ. Mastering the MAD2 framework allows for a mechanistic understanding of these clinical targets, moving beyond the memorization of isolated drug lists. The GI receptor serves as a mechanical lever, enabling the precise pharmacological modulation of the heart, the sympathetic nervous system, and central dopaminergic pathways.